To present on alternate access for TAVR. These are my disclosures. So as the devices have got better, we have these Sapien 3, Evolut FX, and Navitors, these newer generation valves, and we've been more aggressive with balloon angioplasty of the iliac, shockwave, IVL. So we're doing more and more transfemoral, but still with not 100% TF. There is still 3 to 5% alternate access needs. And where it becomes really important is when the volume is low and you need an alternate access. That's where the complications go. If it's a TF case, then whether you're doing low volume, high volume, by and large, your vascular complications are about the same. So as we know, the first TAVR, as we heard in Dr. Leon's talk, was actually done transeptal antegrade TAVR. That's where we started, and then we started transaortic, transapical, but those have all kind of became the last resort. And really, if you're not a TF candidate, then we go either carotid, caval, or axillary. Those are basically our three choices. And at least in the US, we've seen a recent uptake in the carotid and slight decline in the axillary. The yellow bar on the top, or yellow line on the top, is seeing the transaxillary, and the blue is transcarotid with recent increase. So what kind of imaging do we need for carotid, right? Your regular CT scan, make sure you have the cervical vessels to get the carotid artery. And in addition to that, get a carotid duplex just to make sure the contralateral carotid is open. You don't want to put a sheath in the right carotid with a left disease. You can pick whichever is the worst or whichever is the totally occluded carotid. That's okay as long as the contralateral is open. So in addition to CT, only a carotid duplex is necessary additional testing. We don't need to check circle of Willis. We don't need MRI, MRAs. Vascular surgeons have not required that for a long, long time. Right and left really doesn't matter. You can use whichever is more convenient to you. We use typically right carotid. It's a little more ergonomic, but you can use either, and either self-expanding or balloon expandable valves can be used. Sorry, we're going forward. So the incision is made typically right at the level of the thyroid cartilage after you've identified the artery on an ultrasound. Small incision, expose the artery. These are all surgical steps, so I'll skip those details. One thing, when we started carotid, we were doing EEG monitoring, which we no longer do it. One simple thing is once the artery is exposed, you can clamp it and just check cerebral oximetry. Very simple thing, and if you don't see a major step down on the cerebral oximetry, then you're okay to move forward and place the sheath in. Puncture it with a regular needle, put a wire in, put a small sheath in, and then cross the valve just with a 6 or a 7 French sheath, either JR or multi. And once the wire is in the ventricle, you can put a Safari or whichever your wire you're using, and then take the sheath out and place the big sheath in. Once the big sheath is in, you can advance your valve in. If you're using a balloon expandable like a Sapien valve, you do need to assemble it in the ascending aorta. So there is a little careful manipulation of advancing a little bit and then pulling the balloon back. The alternative is you can use a certitude sheath, the transapical sheath, and just place the valve directly mounted on the balloon. But if you're using something like my valve's already on the balloon, so we'll save that hassle. TAVR is then standard. You deploy the valve and take the sheath out and basically repair the artery. So transcarotid versus transaxillary, this is just showing you the trends. The blue line is transaxillary, and what it's showing is that initially there were a lot of centers who were doing axillary, either via cut down or percutaneous, and that trend has slightly shifted towards carotid, where people are doing more and more carotid. And this was basically because of stroke risk. What we saw in registry, TVT registry, was that axillary cases were having higher risk of stroke, something counterintuitive. Carotid was basically acting as a filter, right? You have a big sheath in, so that side is protected for embolic protection for debris anyways. So procedural benefit is more or less the same. Either you're doing percutaneous or surgical cut down axillary, it's almost same as carotid, although in this group they felt their procedural time was shorter, but I think it also depends what your primary alternative access is. If you're doing percutaneous axillary, those patients can very easily go home next day as well. Transcaval, so we haven't seen any excessive risk of stroke with transcaval. In this right table, you see that stroke risk with transcaval was no more than a regular TF case. Their main issue was bleeding, which was seen in axillary cases as well. For those of you who are not familiar with transcaval, this is the animation that has been shown for several years. And the concept is you go from a femoral vein all the way to the IVC. And in the infrarenal area, you puncture the IVC and enter the aorta, the abdominal aorta. This way you've bypassed the diseased iliac arteries. And you go up, place a sheath, then it becomes a regular TF case. Once you're done with the valve deployment, you close the aorta with a plug, leaving the IVC open. So the intuition is, wait a minute, why are we not going to bleed? We're going to have an RP bleed if you puncture the aorta. And the fact is that the pressure in the RP space is higher than the IVC, right? So when you puncture the aorta, the blood's going to go from high pressure to the low pressure. And the lowest pressure is the IVC. So as long as your hole in the IVC is open, that blood from the aorta is going to go into the IVC. So never stent the IVC. So here is a typical analysis that you would need. You basically are measuring the sizes of the aorta. You're making sure there are no vessels, there are no bowel basically between IVC and the aorta. And you can select any point from infrarenal, below the renal, to above the aortoiliac bifurcation. So right in that L2, L3 area, you can pick any spot that does not have calcium on the IVC side of the aorta. You want to stay away if there is a bowel every once in a while in the middle or massive atheroma in the aorta. Sometimes you'll see these calcified dissection flaps that will not allow you to nicely oppose your closure device at the end. So stay away from those anatomies. This is a baseline aortogram. Once your catheters are placed, you take an aortogram just to see what the aorta anatomy is. And this, you can use it as your reference baseline and compare it at the end of the case and see what is bleeding and what is just a branch artifact. On this image, it's a series of step-up catheters and wires. So initially, a 014, like an Astado, a Confianza Pro Water, or a Confianza Pro 12, 014 wire goes in, then you take a 014 exchange catheter. Any 014 would work, like a piggyback, you can use any 014 catheter. And then you advance a 035 catheter on top of it into the aorta. So sequential dilation and upsizing. The back end of that wire is connected to a regular surgical bovie at like a 50 cut mode. So you place a snare in the aorta at the site of puncture through a JR4 6 French guide. The aortic snare is roughly the size of your aorta. So if the aorta is, let's say, 15, 16 millimeters, you can take a 20 millimeter gooseneck snare. And typically, you need two orthogonal views. In an RAO view, which is shown here, AP or slightly RAO, your snare is going to be just like, you'll see us in a single view. But if you go a 90 degrees LAO or like 80 degrees LAO, you'll see that bullseye that we saw in the previous image. And your catheter has to point just in the middle of that bullseye in the IVC. Once your catheters are aligned, you advance an Astado into the aorta, snare it, and then advance it into the aorta, and then it's a sequence of those catheter advancement, like piggyback 014 advancement, and then 035 catheter advancement. Once you have an 035 catheter advance, you have access in the aorta, you place a Lundaquist, and over that Lundaquist wire, you can place either an E-sheath if you're using a balloon expandable, or something like a Cook sheath or a Gore-Dry seal for self-expanding valves. After that, you deploy the TAVR valve, and when you're coming out, you take the big sheath out and basically use an Agilis to deploy this occluder. This is a PDA first generation occluder. Typically a 10 by 8 is good for almost all kind of valves. You use an Agilis just to tilt it 90 degrees to get it really coplanar to your puncture site. Once you're deployed, you can take a picture, and as long as the plug is in the intended position, you can deploy it, because all of the work is going to be on the aortic side. There's nothing more you're going to go on the venous side. So as long as your plug, as is in the left image, is at the puncture site, you can release it, give protamine, and wait for a few minutes. And a lot of times you'll see there is a complete closure. But sometimes you'll see fistula formation. Fistula, and what you don't want to see is the extreme right image, which is the extravasation. You see an aorta and you see vein on the left, and then in the middle you see the blood going in the RP space. You don't want that. If that's the case, then you need bailout strategies like either balloon occlusion or a covered stent. But as long as you don't see bleeding in the RP space, fistula in the IVC is okay. Most fistulas we've seen, either they close at 30 days or definitely at 6 months. So in the interest of time, I'm not going to go in too much detail of axillary. If you're doing a cut down, it's pretty much same as carotid. You just do a cut down and place your sheath, and the rest of the TAVR is about the same. But if you're doing a percutaneous axillary, then you can oftentimes place a safety wire either from the leg or from the radial artery into the axilla, and then use ultrasound guided or even fluoro guided micropuncture and puncture the axillary artery just outside the rib cage, but do stay medial from the femoral, from the humeral head, because then you get into the brachial plexus if you go too lateral. Once the micropuncture access is obtained, you just typically place 2 ProGlides and place your sheath in. So which of these axes is good? Axillary, carotid, cable, it's debatable. It's basically, there is no randomized study head-to-head comparing all the 3 axes. Most of the data is retrospective, observational. There are different centers who have different expertise, and they prefer one over the other. So a lot of this is personal comfort and what your own biases are, what your team is more comfortable with. What I would say is just get comfortable with any one. If you're going to do transcarotid, just do a whole bunch of transcarotid until you're comfortable, and then start exploring the other one. Or vice versa. If you're doing a percutaneous axillary, start doing that and then get comfortable and go over the other. Less debatable is that femoral is the best. If you can stay femoral, then that's going to have less complications. I'm not going to discuss too much IVL. There is a dedicated talk later in the session, but I'm sure you're all familiar with that. Can IVL really eliminate alternate access need? Probably not. It can work in borderline cases, some short straight segments. It works very well, but it doesn't seem to work when you're at a bend at a tortuosity, when it's a very long segment of calcification, or when even the common femoral itself is diseased, then IVL is not going to help you right there. And small vessels, and that's where some new generation system hopefully will further reduce the need for alternate access. Thank you very much.